Okay, so leukodystrophy comes from, of course, the Greek roots for wasting, destruction of white matter. Leuko meaning white, dys meaning lack of, and troph meaning growth. So what is myelin? You can imagine myelin like a wire. So myelin is the fatty substance that goes around the nerve fiber to insulate it. And let me get this, remember it. Okay, this is not going to work like this way. So the wire and the insulation around it, and very similar process with the white matter, with the axon. So you have the nerve, and then the myelin makes the nerve impulse move efficiently. So the myelin-forming cells within the brain are the oligodendrocytes. So there needs to be a coordination between oligodendrocytes, the neurons, and the astrocytes for the normal process of myelination to move forward. It's a very highly energy-dependent process and requires coordination of all these three. So abnormal myelin is going to prevent normal nerve cell conduction. Almost 50% of the brain is comprised of myelinated axons. So you can see that a myelin abnormality can have significant functional effects. So this is a newborn with poor feeding. And as radiologists, we're trained to look and find what the abnormality is on the image. And sometimes we forget to recognize what's actually not there. So on this T2 and T1 weighted image, this is a neonate, and what's missing is normal myelination. So this is what normal myelination should look like. We should have myelin in the posterior limb of the internal capsule and the ventrolateral thalamus. And you can see that in this child here, the myelination pattern is abnormal. So you need to understand what the normal process of myelination is. So myelin normally will progress from the bottom of the brain to the top of the brain, from the back to the front, and from central to peripheral. So the key myelination milestones that you can remember easily at a full-term neonate should have myelination in the posterior limb of the internal capsule and in the brainstem. 3 months old, you should have myelination in the splenium of the corpus callosum. 7 months old, you should have myelination in the genu of the corpus callosum. By 1 year of age, you should be completely myelinated, and then at 2 years of age, you should be completely myelinated on the T2 weighted sequence. There are some areas of the brain that can remain unmyelinated even up into adulthood. That's these terminal zones of myelination around the atria of the lateral ventricles and subcortical white matter. So we can divide white matter disorders into two big categories. The acquired myelin disorders that can be secondary to ADEM, multiple sclerosis, vasculitis, or the inherited myelin disorders, which are going to result from metabolic and genetic disorders. So there was a consortium, the GLIA consortium, comprised of all these experts, and they published this paper in Molecular Genetics and Metabolism in 2015, where they gave the new classification for leukodystrophies and leukoencephalopathies, and this is what my presentation is going to be based on. So the inherited myelin disorders can be divided into two categories: the classic leukodystrophies, which are a result of a genetic defect of the myelin sheath and the myelin-generating cells, and the genetic leukoencephalopathies, where the myelin is affected as well as the neuron. So it's not just an abnormality of myelin. The leukoencephalopathies will primarily involve both. I'm going to be talking about just the classic leukodystrophies, and the definition that the GLIA Consortium has put out for a classic leukodystrophy is heritable disorders affecting the white matter of the central nervous system with or without peripheral nervous system involvement. So in the classic leukodystrophy category that we're going to be focusing on today, there's two big groups, the hypomyelinating leukodystrophies and the demyelinating leukodystrophies, and they can look different. The hypomyelinating leukodystrophies, I'll show you what they look like. It's a T1 and T2 mismatch in signal, and then the demyelinating leukodystrophies where it's a much more prominent T2 hyperintensity. So MR pattern recognition is going to be very important if you're going to have any chance of making a diagnosis here. So we're going to be focusing on pattern recognition. Some patterns are going to be totally nonspecific, but others are going to be pathognomonic. So leukodystrophy, like I said, could be nonspecific in appearance. As you can see here, we have an opiate-induced encephalopathy at the top, which is an acquired demyelinating disorder, metachromatic leukodystrophy, which is an inherited disorder of myelination, what we'll be talking about today, and maple syrup urine disease, for example, which is a genetic leukoencephalopathy involving gray, white, and multiple organs. So it's very important when you see this just abnormal white matter is to make sure you go to the patient history and check the laboratory findings to figure out what you might be dealing with. Leukodystrophy patterns are dynamic and they evolve over time. So it's important to image these cases very early on in the disease when the pattern of injury is going to be more characteristic. Because in the end stage of disease, all of these disorders will look very similar like this. So very frequently I'll have neurology come down and they'll say, hey Susan, you know, what do you think this is? And I'm like, I don't know. They all look the same. So there are three abnormal states of myelination: delayed myelination, hypomyelination, and demyelination. And the way to evaluate myelination on MRI is you want to do your basic T1, T2 flare diffusion imaging, but contrast, susceptibility weighted imaging, and spectroscopy can add additional information that can help us make the correct diagnosis. In order to differentiate delayed myelination, hypomyelination, and the early stages of demyelination, it's going to be very important to get serial MR imaging at least 6 to 12 months apart to allow the myelin to progress. And at least one of those scans has to be after the age of 2 years, when the child is 2 years old, at least, where you expect myelination to be complete, and of course necessary to correlate with the clinical history. So we'll start with delayed myelination. This is it's a nonspecific finding, and delayed myelination can occur with multiple problems that the child may be experiencing. Inborn errors of metabolism, or hypoxic ischemic injury, or Down syndrome, or multiple etiologies. Myelination is very energy dependent, like we said, so any insult to the organism can result in a delay in myelination. And those children will present with developmental delay. So here's an example of a 7-month-old with new onset seizures. On T1 weighted imaging, if you remember the myelination milestones that I talked about, at 7 months we really should have more myelination in the corpus callosum, and we don't. So we're concerned that we may have a delay of myelination. At 1 year of age, you can see how that myelin has progressed and looks completely normal, and the T2 weighted image also is within normal limits for that age. So this represents just a delay in myelination. Hypomyelination, on the other hand, is where you have normal myelin, but just a decreased amount of myelin. So this is normal myelin here and decreased amount of myelin. And these children will present with a motor delay. So these are the hypomyelinating leukodystrophies, and of course I'm not going to talk about all of these, but I will talk just about some of them. It's important to just be able to recognize that you're dealing with hypomyelination, and then try to find other findings that may help you specifically make the diagnosis. So I'm going to show you some examples. So this is a 4-month-old with hypotonia and nystagmus, and doesn't really look very abnormal for a 4-month-old. You know, maybe looks like there's a delay in myelination a little bit. The corpus callosum could have a little bit more myelination. This was read by somebody as a normal examination. The child was lost to follow-up and came back to the hospital. Now the child is 4 years old and has spastic diplegia. And so what we can see now is the cerebellum looks a little bit smaller. We have normal progression of myelination on the T1 weighted imaging, but if you look at the T2 weighted image for a 4-year-old child, that doesn't look normal. There's not enough dark signal there for where you would expect to have with a normal amount of myelin. So this is what hypomyelination looks like on T1 and T2 weighted imaging. And this is HABC syndrome, which stands for hypomyelination with atrophy of the basal ganglia and cerebellum. And I forgot to point out to you that actually you can see that the thalami and the basal ganglia look sort of dense and small. So the combination of these findings can lead you to this diagnosis. This is sporadic. The children present with motor delay. They can have cognitive decline and have the characteristic findings that I pointed out to you. So here's another example of a hypomyelinating leukodystrophy. This is a 15-year-old with developmental delay and ataxia and no other symptoms. And the brain, you know, it doesn't look very good. So the thing is that on the T1 weighted imaging, the myelination could look normal, but sometimes it can look undermyelinated, so it can be a little tricky. But the T2 weighted image, you can see the white matter just diffusely looks a little bit too bright. It's not that confluent, intense white matter signal abnormality that I showed you earlier. It just looks like there's not enough myelin there. And additionally, you can see that the thalami and the basal ganglia look very small and very dark. And again, that cerebellum looks atrophic. So you should be suspecting that this child could have hypomyelination, and you want to go into the chart and ask some questions, because this child here also had abnormal teeth. The teeth weren't coming in, they were abnormal in shape, and also the child had small gonads. And so the combination of all of these findings can lead you to the diagnosis of 4-H syndrome, which stands for hypomyelination, hypodontia, hypogonadotropic hypogonadism. So that way, easy, you can make the diagnosis now. So talked about the MR findings, and I won't go over that again because you know it now. So hypomyelinating leukodystrophy, another case. This is a 6-day-old with vocal cord dysfunction. For a 6-day-old, as you know, based on the milestones that I showed you, that there's not enough myelination there. We should have myelination in the posterior limb of the internal capsule, and we don't. So we ordered a follow-up examination. We're concerned that we're dealing with a leukodystrophy, and 6 months later, the patient has truncal hypotonia, hypertonia, and rotatory nystagmus, and there's been no progression of myelination. Notice again, we don't have enough myelin there, and this is a classic example of Pelizaeus-Merzbacher disease, which is a hypomyelinating syndrome. It's X-linked recessive, It's characterized by rotatory nystagmus. The children have quadriplegia, developmental delay, slowly progressive, but they sometimes can live up onto middle age. And that's basically what that looks like. So now we're going to move into demyelinating leukodystrophies. So here's an example of normal myelin, and this is what normal myelination looks like. So these children have been progressing normally, but then they lose their milestones. So they're going to have motor regression, and that's what's typical for demyelination. So first case, Canavan's disease. And I don't know why it's coming up like that, but this is an autosomal recessive syndrome. So there's a 1 in 4 chance that one of the children will have this disorder. There's a spongiform degeneration of the white matter that you can see here. That's what happens histopathologically. There is early involvement of the subcortical U fibers in Canavan's disease, so it starts from the periphery and then it can extend to diffuse demyelination. Interestingly, the globus pallidi and the thalami are involved with sparing of the caudate and the putamen. So that's another key feature. If you do spectroscopy, you can see this very high dominant NAA peak. This is one of the few instances that MR spectroscopy can actually be helpful in making the diagnosis. And then these children typically have large heads. And this disease is more prevalent in the Ashkenazi Jewish population. It was first described by Myrtle May Moore Canavan in 1931. She was a neuropathologist. She worked at Boston University and then was a curator for the pathology department at Harvard, but they never made her a full professor because she was a woman. Very sad. X-linked leukodystrophy. This is a paroxysomal disorder with an X-linked recessive mode of inheritance. Now, you don't need to remember all that, but they make nice, colorful slides. So the peroxisomes are responsible for oxidation of very long-chain fatty acids. So the classic imaging appearance for X-linked adrenoleukodystrophy is going to be intense symmetric signal abnormalities that involve the splenium of the corpus callosum. You can have enhancement around the edge of that demyelination, and they typically occur posteriorly. There is an atypical form that can present in 20% of the cases where the abnormality is in a frontal distribution. Diffusion imaging can be helpful. It can show us an advancing edge of diffusion restriction, and then these children also can have adrenal insufficiency with the bronze skin. So there was a movie that was made about a child with X-linked adrenoleukodystrophy called Lorenzo's Oil that Susan Sarandon starred in, and it's a true story about this child. His father formulated this oil that had very low levels of long-chain fatty acids, and he was doing okay for a while, but unfortunately it's a progressive disease. He became blind, couldn't communicate, and died at age 30. And that is actually a picture of him. Next, metachromatic leukodystrophy. This is a lysosomal disorder with an autosomal recessive mode of inheritance. So 1 in 4 chance that the children will get it. It's due to accumulation of this cerebroside sulfate that causes demyelination in the central and peripheral nervous system. The classic MR appearance is going to be a butterfly configuration of the abnormal signal. Notice in these demyelinating leukodystrophies how intense and abnormal the T2 signal is in the white matter versus the hypomyelinating syndromes that I showed you. And also we can have this tigroid appearance, just these spots of myelin sparing around the vessels. sparing of the new fibers, and no evidence of any enhancement, unlike the X-linked adrenoleukodystrophy. And these children will present with progressive loss of developmental milestones. They can stop walking, breathing, talking, reasoning. Krabbe's disease. This is another lysosomal disorder, and it's caused by an accumulation of globoid cells within the white matter due to an enzymatic defect. So these globoid cells are which are partially causing the abnormality. And on imaging, what we're going to see is hyperdense thalami on CT, and they're going to look hypointense on T2 weighted imaging. We're going to have demyelination of periventricular and cerebellar white matter. Interestingly, you're going to have enlargement of the optic nerves because of the deposition of these globoid cells. And the way I remember it is Krabbe, and this is Mr. Crab from SpongeBob SquarePants with the big eyes. So remember, look at the eyes. So I just have to use little tricks to be able to remember. So you're going to have enlarged optic nerves, and you can have enhancement of the cauda equina as well, if you remember to look down there. The clinical presentation in the infantile form is these children have significant irritability. Alexander's disease. This is a sporadic genetic mutation that can actually have a dominant mode of inheritance. So there's a 50-50 chance that one of the children can get this. This is very interesting because it's characterized by accumulation of Rosenthal fibers right here. And these are the same fibers that you see with juvenile pilocytic astrocytoma. And perhaps this is why we have the imaging appearance that we do. So Alexander's disease, we're going to have involvement primarily in the frontal region of the brain. So frontal lobe white matter, symmetric involvement of the basal ganglia. You can have this rim of low signal around the ventricle with high signal on T1 weighted imaging. And if you happen to give contrast, you can see these areas of abnormal enhancement. You can have involvement of the brainstem right here with enhancement. They can actually be confused with a tumor like this child was right here. So it's very interesting how these Rosenthal fibers affect the appearance in Alexander's disease. Also characterized by macrocephaly. I like to remember it Alexander the Great with the big head. So that sort of helps me. Megalencephalic leukodystrophy with subcortical cysts. The name actually says what you're going to be looking for. This is a genetic mutation with autosomal recessive pattern of inheritance. On neuroimaging, what you're going to see are these classic subcortical cysts that are going to occur in the anterior temporal lobe region. You're going to have abnormal white matter signal, and the basal ganglia are going to be spared in this disorder. And the clinical course for these patients is actually very mild. It's found more frequently in the Agarwal Indians. First described by Dr. Marjo Vandernap. And then vanishing white matter, likely a genetic etiology, not sure, has an autosomal recessive pattern of inheritance. And what we see in this disorder is this rarefaction and microcystic changes that occur in the white matter. And this white matter degeneration, interestingly, can be triggered by a minor head injury, very, very minimal. And then all of a sudden, their white matter starts melting away. So they get these diffuse, abnormal white matter signal, and slowly the white matter disappears, and there's preservation of gray matter. So that is vanishing white matter disease. So this is an MRI algorithm that was developed by Dr. Vandernap and other experts in the field, which just delineates an MR-based approach to the diagnosis of white matter disorders. I like to keep this in the background and refer to it if I need to. What I do is just try to very simply just remember a few things that are going to help me go in the right direction and use these MRI discriminators. First discriminator, is hypomyelination present? Is there a mismatch of T1 and T2 signal? Second discriminator, what is the distribution of the white matter signal abnormalities? Are they bilateral, symmetric, and confluent? Think about leukodystrophy. Of course, as I showed you, it could be due to acquired white matter disorders as well, but just go to the history and look at the clinical findings as well. The third discriminator is what is the distribution and the appearance of these confluent white matter changes. If they're going to be subcortical in distribution, I'm going to think about Canavan's disease. Now remember, this is all imaging that has to occur early on in the process of the disease. If you wait until the end, everything's going to look the same. If you have parieto-occipital distribution with enhancement, think about X-linked adrenoleukodystrophy. Periventricular distribution with a tigroid pattern, think about metachromatic leukodystrophy. Periventricular abnormality of the white matter, dense thalami, large optic nerves, think about Krabbe's. Frontal distribution with abnormal enhancement, think about Alexander's disease. Anterior temporal cysts, this is going to be megaloencephalic leukodystrophy with cysts. And then the diffuse white matter loss, just melting away for no reason, vanishing white matter disease. And in addition to the MRI discriminators, always look for clinical findings that can help point you in the right diagnosis. Thank you.